And I'm Riley, and we are going to be talking about nursing care of a family when a child has an immune disorder, which is chapter 42 of our textbook.
Yes.
So we are going to start out with just talking about the immune system, kind of a general overview of that. So immune system is composed of a variety of cells and proteins, and these cells will either recognize or react to antigens, such as foreign substances in the body. And antigens can be pathogens like bacteria, viruses, fungi, or they can be food proteins or pollens, things like that. And then the immune system response includes host defenses, which are like physical protective barriers like the skin or mucous membranes. Also includes nonspecific responses, which include complement phagocytes and natural killer cells. And then specific responses, which include antibody production and cellular immunity. So phagocytosis is a big part of the immune response because that is what destroys those foreign invaders. So this will occur if an invading pathogen makes its way past those physical protective barriers. And then the body's immune response will provide that immediate protection, and then it also kind of creates a template for how to destroy those same antigens again in the future. So antigens can be either immunogens or allergens, and an immunogen refers to an antigen that can be readily destroyed by the body's immune response, and then an allergen is an antigen that causes an allergic reaction in the body. So allergens can enter the body through various ways, can include ingestion, inhalation, injection, or they can be absorbed across membranes. So then the types of immunity are humoral immunity, complement activation, cell-mediated immunity, and then autoimmunity as well. So all of the cells of the immune system originate in the bone marrow, where they develop from stem cells. And then some of those major organs of the immune system are the thymus, liver, bone marrow, spleen, tonsils, lymph nodes, and blood. So two major types of cells involved in the immune system are B lymphocytes and T lymphocytes. So B lymphocytes will produce antibodies or immunoglobulins, which will bind to specific antigens and then destroy them. And then memory cells will also retain that ability to produce those same immunoglobulins again in the future. So if those same antigens return, the body will be able to kind of prevent an immunocompetent individual from getting that disease again. And then T lymphocytes account for 70 to 80% of the lymphocytes in the body, and they mature under the influence of the thymus, and they're responsible for cell-mediated immunity and include cytotoxic killer T cells, helper T cells, and then suppressor T cells. So there's two major types of immunodeficiency. There's primary or congenital, and then there's secondary or acquired. So a big example of a primary or congenital immunodeficiency is called severe combined immunodeficiencies, or SCID, which is an inherited group of rare disorders that are associated with defects in the T and B cell immunity. And then an example of secondary immunodeficiency that we're all pretty familiar with is HIV and AIDS. So just to touch a little bit on HIV infection and AIDS, it's transmitted through exposure to blood and or body fluids through sexual contact, perinatally from a mother to a fetus, can be spread through sharing contaminated needles or by receiving a transfusion of contaminated blood or blood products. And then transmission of HIV through the placenta from a mother to an infant is actually the most common reason for childhood HIV infection in the US. So therapeutic management of HIV infection, kind of both for children and for pregnant women who are HIV positive. Education for HIV positive women that kind of focuses on increased birth control and then antiretroviral medications is important. And then for both children and women who are pregnant with HIV, they're probably going to be on a medication regimen that involves multiple drugs, and then they'll also likely be on some prophylactic drug therapy just for any other opportunistic infections or illnesses that might present themselves. For children especially, routine immunizations are really important, still just kind of appropriate for their age and the state of their infection. And then strict personal hygiene strategies are also important, so just frequent hand washing and avoiding other people who might be sick. And then finally, it's just really important during pregnancy and the labor process for fetal exposure to maternal blood to be restricted as much as possible if the mother is HIV positive.
Okay, now we are going to move into allergic diseases. So allergic diseases occur as a result of abnormal antigen-antibody response when the invading organism is an allergen rather than an immunogen. And symptoms can be chronic or minor and can disrupt a child's life and development. And there are 4 types. There's type 1, which is immediate, and that involves cells IgE. And that is like allergies, asthma, atopic dermatitis, anaphylaxis. Type 2 is cytotoxic, that involves the IgG cell and the IgM cell, and that's hemolytic anemia, transfusion reaction, and erythroblastosis fetalis. Type 3 is immune complex, that involves IgG cell and IgE cell, and that's your rheumatoid arthritis, systemic lupus. And type 4 is delayed, and that involves the T lymphocyte, and that is your contact dermatitis and transplant graft reaction. Okay, so there is familial tendencies with allergic diseases. So when you're doing your family or your history or patient history, you want to know family history of allergies and the exact symptoms of the allergy. And for laboratory testing, you're going to be looking for the presence of IgE antibodies, which are detected in serum or via skin testing. And these are both useful biomarkers. Skin testing is done to determine potential triggers for atopic symptoms. And then scratch, prick, or puncture are done for detecting sensitivity to foods, stinging insects, and some drugs. Okay, and for therapeutic management, you're going to have your environmental control, pharmacological therapy, and immunotherapy. Your goal for therapeutic management is to reduce the child's exposure to the allergen and modify the child's response to the allergen. Environmental control is going to be limiting exposure, washing bed linens in hot water every 2 weeks, using non-scented products, and your pharmacologic therapy is intranasal steroids, 2nd and 3rd generation antihistamines, and decongestants. And immunotherapy is done when neither environmental control nor pharmacologic therapy are helping the situation. Thank you. Okay, so anaphylactic shock. For assessment, you're going to be looking at breathing, circulation, skin, stomach, and other areas as well. For breathing, there's going to be potentially wheezing, shortness of breath, throat tightness, itchy mouth and throat, cough, hoarse voice, chest pain, tightness, nasal congestion. Circulation, patient is going to be pale, blue in color, low pulse, low blood pressure, dizziness, loss of consciousness, shock. For skin, you're going to notice hives, swelling, the patient will be itchy, warm to the touch, redness, rash. They might be nauseated, pain, cramps, vomiting, diarrhea, and then also they might have anxiety and itchy red watery eyes and headache. And for therapeutic management, epinephrine injected IM is the standard care for treatment for anaphylaxis regardless of the cause. And then other treatments might be oxygen, IV fluids, nebulizer, and corticosteroids may be administered as a second-line drug. All right. urticaria and angioedema are other common allergic reactions. Urticaria, those are hives. They're intensely pruritic hives, and they're often described as a burning sensation. And they may occur close together that they blend. They're so close together that they blend, and then it makes it look bigger than it is. In chronic urticaria, it is possible that there's no causative allergen that can be found. In angioedema, that is edema of the skin and subcutaneous tissue, and this occurs most frequently on the eyelids, hands, feet, genitalia, and lips. It can be differentiated from other edemas because it's not dependent, it's asymmetrically distributed, and it occurs in conjunction with urticaria. Urticaria.
Difficult words.
Very difficult words. Okay, atopic disorders. The first one we're going to talk about is allergic rhinitis. This is associated with an IgE-mediated inflammatory response to allergen exposure. And the assessment, common symptoms you're going to see are congestion, sneezing, nasal engorgement, runny nose, red itchy eyes, itchy sore throat, post-nasal drip, and cough. Allergic rhinitis is a risk factor for development of asthma, and it can have a huge impact on the quality of life of the person, including there's sleep impairment and decreased work-school performance. For therapeutic management, you want to avoid the offending allergens, and then you want to use pharmacological agents such as antihistamines or corticosteroids. And then you can also do immunotherapy. Okay, and then there is perennial allergic rhinitis. So that's allergic rhinitis when it becomes year-round. And the allergen is one that is present in the environment year-round. So that's usually things that are indoors, such as dust mite, mold, animal dander, and cockroaches. And yes, very yucky. And so you'll see postnasal drip and nasal congestion.
Thank you, Bree.
You're welcome.
All right, now we're moving on to atopic dermatitis, or infantile eczema. So assessment with this, infants will usually present with a rash on their face, neck, and extensor surfaces. And management for this, we're treating it, the goal is to reduce the amount of allergen exposure, so that's kind of the main treatment. And then we can also hydrate the skin by bathing or applying wet dressings to the affected areas. So then atopic dermatitis in older children. Assessment of this, so it's gonna be prominent on the flexor surfaces of the extremities and on the dorsal surfaces of the wrists and ankles. So kind of looking for it there. And then the lesions are gonna itch intensely, and the child's gonna probably be scratching more vigorously because of this increased discomfort. So therapeutic management for this, prescription soap can be useful, swimming in chlorinated pools, application of hydrocortisones, and then phototherapy with ultraviolet light. Just one thing too to note with dermatitis in the older child is that it can be especially difficult for them because they are scratching more, which can lead to depigmentation of their skin. And at this age, they're kind of paying close attention to how they look, and their appearance is kind of getting more important to them. So just an important consideration when caring for those kids. So drug allergies are next. So just first to talk about the differences between toxic reaction side effects and allergic effects. So a toxic reaction occurs when a child receives too much of a certain drug. And then side effects are those that are known to occur in addition to the therapeutic effect of a drug, whereas an allergic effect is referring to symptoms that are unpredictable. So allergies are rarely known to occur with orally administered drugs, with the exception of antibiotics, aspirin, and NSAIDs. And children with atopic diseases are actually most prone to allergic drug reactions. So treatment should involve kind of just a lot of prevention strategies, having children who do have a known drug allergy wear a medical identification bracelet, and just kind of keeping track of what drugs kind of cause certain effects. So injectable drugs are most frequently involved in allergic reactions. The ones that are most common are cephalosporins and penicillin. So typically treatment for that is just discontinuing those medications and avoiding them in the future. But Benadryl can be given for kind of mild symptoms of an allergic reaction, and then epinephrine should always be given for anaphylaxis. So then food allergies. These are an abnormal immune response caused by exposure to a food protein. So food allergies can be IgE mediated or mixed reactions. And then symptoms kind of vary among children, just kind of depends, but general symptoms might include urticaria, angioedema, and flushing. So assessment of food allergies, the first known exposure to milk, egg, or peanuts causes an immediate, oh gosh, what just happened? There we go. Okay. It can cause an immediate type 1 response, which can produce hives, swelling, and vomiting. But an elimination diet can be an effective tool to detect mild food allergies. And then therapeutic management of this, the easiest treatment for a food allergy is just to eliminate that food from the child's diet and avoid that in the future. So vaccines, mild local reactions and fever after vaccinations are common, so they're not necessarily allergic reactions. And anaphylactic reactions to vaccines are rare. So children who are allergic to eggs can and should still receive injectable influenza vaccine as well as the MMR vaccine. And then the yellow fever vaccine requires special precautions for children with an egg allergy. So then milk intolerance. This is one of the leading causes of type 1 reactions to foods. And not all milk reactions are IgE-mediated reactions. So most infants can tolerate breast milk even if the mother consumes milk. Assessment of this milk intolerance usually presents in infancy and then is typified by failure to gain weight, diarrhea, maybe some vomiting, and abdominal pain. And then therapeutic management, supplementing with a hydrolyzed protein-based formula usually decreases the symptoms of that milk intolerance.
Thank you, Riley.
Yes, take it away.
Okay, so now we're going to get into peanut allergies. Peanut and tree ingestions are the cause of more than 85% of fatalities caused by food anaphylaxis in the United States. And children at high risk for developing peanut allergy include those 4 to 11 months old, and diagnosed with egg allergy and or those with severe eczema. And there is a significant interest in preventing peanut allergy rather than dealing with the consequences once the allergy has developed. Okay, now stinging insect hypersensitivity. Children may have severe hypersensitivity reactions to stings from bees, wasps, hornets, or yellow jackets. And the usual reaction to these stings is immediate type 1 or anaphylaxis. And teaching for children who are allergic to stinging insects would be to avoid scented products such as hairspray, perfume, scented lotions, because these things attract insects, and then they also are not to be given chores such as mowing lawn or yard work duty. And then they also should not go outside barefoot because bees are often found in ground clover. For therapeutic management, the child who has not been hyposensitized must be treated immediately after sting by an injection of epinephrine. And then also if you apply ice to the site, it minimizes the amount of venom that's absorbed. All right, contact dermatitis it's a delayed or type 4 hypersensitivity response. It is a reaction to skin contact with an allergen. I can't talk.
Yeah, it's okay.
Assessment, you want to do patch testing, maybe used to identify contact dermatitis allergens. And then therapeutic management would be removing the identified allergen from the child's environment. Dressings moistened with water, saline, or Burroughs solution relieves itching. You can use calamine or calatril lotions, hydrocortisone lotions or creams, reduce itching and also promote healing. And then if it's a large area of the body that's involved, you can do baths with baking soda or oatmeal in the water, of course. I gotta edit this slide.
You can do it.
You can do it.
Okay, just talking a little bit about health promotion and risk management. So some methods to help prevent autoimmune disorders can include avoiding certain toxins, just things like air pollution, lead, mercury, pesticides, things like that. And then also eating an anti-inflammatory diet and maintaining a healthy weight can be useful methods to prevent autoimmune disorders. Improving gut health as well through prebiotic and probiotic supplements, and then quitting smoking and getting adequate amounts of sleep can be useful. So then prevention of allergies in children. One method for preventing allergies is exclusively breastfeeding children for the first 4 to 6 months of life, because this can strengthen the immune system and then delay or prevent atopic dermatitis and milk allergy. Another method of prevention is to introduce solid foods gradually between 4 to 6 months of age. And then also reducing exposure to just certain allergens like dust mites and things like that can help to delay or prevent allergies. And then finally, just some health promotion notes. So avoiding exposure to known allergens is important, as well as taking any medications that are prescribed to you. If you do have an epinephrine auto-injector, always having that on you, making sure children have that with them, know how to use it, or people around them know how to use it if they are at risk for anaphylaxis. Also wearing a medical alert bracelet for children can be really important, and then knowing what to do in the event of an allergic reaction.
Thank you so much.
You are welcome.
All right, cultural considerations. So you want to look at the diet of their culture, and it's possible that the child may be allergic to some of the foods that are part of their cultural foods. So you want to talk with the parents and make sure that you're being respectful of their foods, and try to find a way where the kid is still participating in meals. And then for vaccines, you want to know what the cultural beliefs are regarding vaccination. There may be some cultures that do not do every vaccine, or they just have different views on vaccines, and you want to also be respectful of that as well. And then you want to know how the culture views health and illness, and how they view immune disorders, and what that means for them. And then you also always want to determine if there is a need for an interpreter, and if so, make sure the interpreter is a professional interpreter, and make sure you are speaking to the patient, not the interpreter. All right, holistic client-centered care. So you just want to maintain eye contact when you're speaking with the patient. You want to keep the communication simple, avoid using medical terminology, listen to and acknowledge their concerns, be honest with them, be truthful, tell them the specific name of their disorder, and describe how the disease relates to their individual history. And then you can discuss what the patient should expect from their diagnosis, help the patient understand their treatment and how it will impact their daily life, provide time for the patient to ask questions, and then you also want to provide any kind of emotional support for your patient and the family as well. And that concludes our project, chapter 42.
Thank you.
Thank you.